Hey, hello, you guys. Let's go ahead and get started. As a matter of introduction, my name is DJ. I'm currently the EMS training captain with Gilpin Ambulance Authority. But some of you may remember me with by my time with Flight for Life, Colorado. Um, this was always one of my most favorite conferences to go to. And you may remember my little booth I had over in the corner of the cafeteria. And those who know me know that I have just a tiny little bit of OCD. And so that being said, I had a very particular way that I liked my booth to look. But the damnedest thing, every once in a while, I'd go to my hotel and come back the next morning and it looked like a tornado had come through. Now, who, you ask, would ever do such a thing to such a nice person as myself? Well, you need look no further than this guy right here. But as mentioned, always one of my favorite conferences to go to. I always appreciated kind of the family feel of this conference. Kim's wife oftentimes was doing the lunches, and you'd see his Kim's kids and grandkids running around. So I always really liked this conference. The other reason is it's pretty much the only time of the year I would ever get to drink Tang, and I love Tang, but I never get it, and it was always at this conference. So why, you ask, am I, of all things, doing a presentation on OB emergencies? Well, the answer is, a lot of folks just are not comfortable with OB calls. I am absolutely one of those people. Um, it's also relatively hard to get CE, probably because nobody likes to teach it either. Whenever I'm recertifying one of my crew members, it always seems like OB is the one that they're missing. So, for all you guys who will be recertifying, here's a check off that you'll have. I've also found in my years of service that really the best way to learn things is to teach them. Even doing this presentation, writing up this presentation for you guys, I learned a ton of stuff, and so it's always tremendously helpful. The only way you really can get comfortable and confident in running these calls is to just fill your minds with knowledge about these kind of calls and what to expect and that kind of thing. And then finally, the last reason is I have a nightmare call that I would love to share with you guys so that if you should ever face the challenges I did on this call, you will at least feel a little bit more comfortable. So today we're going to go over 4 of the most common complications associated with pregnancy and delivery. Those being placenta previa, placenta abruption, HELP syndrome, which some of you may or may not have ever even heard about, and finally an incompetent cervix, which once again you may or may not have ever even heard of. So before we get started, we'll just do a real quick little review of A&P. The placenta in pregnancy is a big kind of ball of goo that is attached to the wall of the uterus. The placenta provides a space for the just a ton of little veins and arteries, and it allows for exchange of oxygen and CO2, as well as the exchange of nutrients and then getting the waste out of there. It's attached by these little finger-like villi that are, I'm not going to try to, well, I'll give it a shot. Cotyledonary villi, which are what attach to the wall of the uterus. And All those villi are little vessels that again are involved in that exchange of the oxygen and the nutrients. After delivery, these villi just naturally collapse as there's no more blood flow and separate from the uterus. Typically, this is somewhere around 5 to 15 minutes after delivery. The umbilical cord is somewhere around 2 feet long. It extends from the placenta to the baby. This provides a nice highway for the veins and the arteries and the uricus to travel. It is protected by a layer of what is called Wharton's jelly to cushion those vessels and protect them. Here's a cross section of an umbilical cord. The interesting thing here is that it's a rare time in the body where the artery is actually carrying deoxygenated blood and the vein is carrying oxygenated blood. And so that's more in line with the baby's artery and vein system. And then as far as it going out to the placenta. And again, this is the area that's cushioned by the Wharton's jelly. Now, some of you older, perhaps more seasoned medics might find a similarity in this cross-section of the cord and the Mr. Bill character from old Saturday Night Live skits. I'm sorry, this is just the way my mind works. The first thing we're going to talk about today is a complication called placental previa. This one isn't necessarily as much of an emergency, but interestingly, it's the leading cause of bleeding in the first trimester. This is where the placenta has placed itself in a pretty poor position and partially blocks the exit of the baby. Oftentimes, this being in the first trimester, a physician is able to manipulate the placenta and sort of get it out of the way, or it even oftentimes will self-resolve. Again, this one isn't necessarily a huge emergency, but it does give you an idea if there is some mild bleeding and no pain, you can perhaps start thinking placenta previa. So a few facts about previa. It actually, interestingly, affects 1 in 200 deliveries. Mortality rate is very, very low. It does, unfortunately, put you at a higher risk for abruption, and we're going to talk about abruption a little bit later on. As mentioned, less of an emergency, and it often will resolve on its own. The risk factors for previa are going to be tobacco use, a history of previa or abruption, prior surgeries down in that area, whether that be an ENC or removal of things, anything along those lines. It could leave some scar tissue on the uterus, which might have the placenta land in the wrong spot. Maternal age over 35 is also a big risk factor here, as well as drug use and if the mother has had babies in the past. The key point here is to really get a good history. We're going to talk about history here in a little bit, but on these patients, history is really an important factor. These patients are going to present to you with mild bleeding that is just a little bit a little bit more than normal. They're typically going to be in their first 20 weeks uh, of pregnancy. They may actually present to you in preterm labor, which is a little bit scary. And oftentimes, this one is actually going to be pain-free. So the key point here is really not a lot of pain and mild bleeding. So in this one, I want you guys to do your primary exam just like you would always do your primary exam. You want to do, you know, look in there, look at your patient, you're going to note mentation. I'd really like you though to emphasize circulation and blood pressure. If this turns into a bleeding situation, which again is rare, the pressure could be low. If the pressure is very high, then we might be talking about preeclampsia type situation or a HELP syndrome situation. In your history, I want you to take your normal history, past medical history, meds, allergies, but I'd like you to emphasize the gestation, gravidipara, gravida being how many times the mother has been pregnant, para being how many live births that she has had. Another really good question is if the mom has been following up with an OB, a GYN, and even further, if she has been compliant with the regimen. As mentioned, prior complications are a big component here. The pain versus no pain with the bleeding is going to point you perhaps in a direction of previa versus abruption. And then, of course, drug and alcohol use and the estimated amount of blood that the patient has lost. On your secondary exam, again, want you to do a full head to toe with an emphasis, though, on skin color, how much blood is lost. If this patient is contracting, you can check fetal heart tones. I don't know if any of you have ever really listened, but with just a regular stethoscope, you can indeed hear fetal heart tones. You just have to be careful not to mix them up with the mom's heart rate or even yours. And the other thing to look for in your secondary is bulging or edema. How are we going to treat this patient? So ABCs, of course. We always start with ABCs. Seems safe, BSI. You're going to want to take frequent vitals on this patient. Again, monitor those fetal heart tones. You're going to sound very cool if you walk in and give vital signs for the mom and also mention fetal heart tones. Oxygen. I don't know why, just it seems like these patients should have oxygen. So, and then perhaps consider an IV in the event that this does become a bleeding situation. You want to provide supportive care. Keep the patient calm as well as yourself. Keep the patient warm, I guess, as well as yourself if you'd like. You should always consider transporting your OB patients in the left recumbent position. What this does is takes the pressure off the vena cava, the mother's vena cava, which allows for better blood flow. And then, as always, reassess. We will talk about transport a little bit more in depth a little later on in this presentation, but the transport decision is really, really important. Are you going to go to the local hospital? Are you going to make a run for Colorado Springs or Denver? Or is this a situation where Air Medical might be helpful to you? Back to that history. Again, in addition to your past medical history, meds and allergies, Again, these are the items you really want to hit. You want to know how long along we are. You want to know gravida and para. The easy way to remember gravida and para is the letter G. It comes in the alphabet before the letter P. And so again, gravida is the number of times the patient's been pregnant versus the P, which is how many live births there's been. You want to ask your patient about complications with this particular pregnancy, and you also want to talk to her about any complications with previous pregnancies. Again, you want to ascertain whether she has been receiving prenatal care, and again, whether she's been compliant with that. If the patient is contracting, you're going to want to take note of not only how often the contractions are happening, but how intense they are and how long they last as well. You want to ask the patient how much bleeding she has noted. You want to ask her again if there is pain or no pain. This again will help you distinguish between previa and abruption. The other thing to ask the mom is whether she has felt the baby moving as much as perhaps in the past few weeks, or no movement at all. That can also be an indication of how serious this is. And then again, alcohol, drugs, and cigarettes. So remember these when you're doing your history. It's more than just past medical history, meds, and allergies. There's a whole slew of questions that are going to be very important for you to ask of any of these OB patients. So that's it for previa. Does anybody have any questions? I'm just kidding. This is a recording. You can't ask questions. But if you do have any questions, this is my email address, and you may feel free to email me at any time. Let's talk about abruption. Now, this one is a little bit more of an emergency. This one can be a little bit more scary. So what happens in abruption is when all those little tiny villi that we spoke about have separated by some mechanism from the wall of the uterus. Unfortunately, as I'm sure you guys know, what this does is interrupts the blood flow to the baby, as well as just causes a hemorrhage in the mom. So there's a few myths out there that's abruption will occur with stretching or sneezing or coughing or intercourse, which I suspect these two gentlemen don't have a lot of. But those are all just myths. Those typically speaking will not cause an abruption. So there's three different kinds of abruption. Grade 1, we're not terribly concerned about. This is going to be a small amount of bleeding, and the patient may start contracting on you, which again can be very scary if they are preterm. Grade 2 is you're going to have a little bit more bleeding. You're going to have some pain, and you're going to need to treat this one a little bit more importantly. And then grade 3 is really where the separation has really occurred. You're going to have a lot of bleeding, a lot of pain. You potentially could have a low blood pressure in the patient. And this is where we really start thinking about fetal demise and the importance of getting this patient to the right hospital. Some of the risk factors here are pretty much the same as what we saw in the placental previa. A history of abruption or previa, hypertension, those surgical procedures that we spoke about. Maternal age, actually greater than 36, puts you at a higher risk. of having an abruption. And then, of course, as mentioned, trauma and substance abuse. I'm really harping on history here because really it's going to lead you down the right path and help you decide just how much of an emergency this is. So again, just keep in mind that history is just so important. These patients will present oftentimes with heavy bleeding. This one does have pain associated with it. Decreased fetal movement, as we talked about before. They may be contracting, which again is very scary, and they might feel faint because they are losing blood. So you're going to kind of treat these patients as you might a hemorrhagic shock type patient. So as mentioned, this is bad both for the baby as well as for the mom. So we've cut off the nutrients that are going to the baby. We, more importantly, have cut off the oxygen that is going to the baby. It could cause preterm labor. And then finally, if it's not addressed and addressed correctly, we might be talking about fetal demise. The effects on the mom, as mentioned, bleeding, shock. You can run into some clotting disorders. And with the lack of blood, going to the organs, it can lead to multi-organ failure in the mom and even can certainly result in death if some of these aren't corrected. So again, I'm going to have you guys do your normal primary exam, ABCs, all that kind of thing. I'm going to have you guys emphasize, though, once again, mentation, circulation, and blood pressure in the mom. This is something that I would have you guys keep a really close eye on, again, secondary to the potential of the mom going into hemorrhagic shock. The biggest thing from just simply a low blood pressure to we've now gone to shock, if you guys don't know, is oftentimes mentation. That's going to be our big key, and of course, blood pressure. In your history, I don't need to repeat this again. Just remember that the history is super important. On your secondary exam, just do your normal secondary exam as you normally do, looking for trauma and all that kind of thing. But I really have you guys emphasize, again, mentation, the mom's skin color, estimated blood loss, fetal heart tones, and then if the mom has any edema noted in her extremities. And then transport. Once again, transport is a pretty important piece of this. So are you going to go to Holyoke? Are you going to go to the Springs? Are you going to go to Denver? Or is this a time when Air Medical is going to be your friend? And then as far as treatment, much the same, frequent vitals, monitor those fetal heart tones, give the patient oxygen, and then certainly an IV, and be ready to give an IV bolus. Same supportive care that you're going to provide, as well as your transport decision. So let's talk about Air Medical for a little bit. Some of you know that I have a little bit of history in this field. It used to be that you guys out in the plains were at a terrible disadvantage relative to air medical transport, but now you can't swing a dead cat without hitting a helicopter out in your area, so that's a good thing. And so in my years of Flight for Life, I always told people there's really two reasons that you call a helicopter. One of them is for the speed in which they can get your patient to where that patient needs to be. For example, the cath lab, the trauma OR, that kind of thing. The second reason that you call a helicopter, the other reason you would call a helicopter, is the medication or procedures or equipment that they can provide that are at the crit care level. So this one actually, relative to OB calls, this is a really good use of helicopters because they can provide both the speed in getting the patient where they need to be, as well as some medications and equipment, which we'll talk about a little bit later, to the patient. So do consider air medical in these situations. Now, the other thing to consider is most of these air medical services have ground units. And so if the weather is crappy, just understand that oftentimes they will be very happy to jump in an ambulance and meet you halfway if that's something that would be helpful. Third thing we're going to talk about, and actually it's even scarier, is a syndrome called HELP syndrome. And it's actually an acronym that describes these four components here. H being for hemolysis, the EL being elevated liver, and the LP being for low platelet count. I added this circle because I just needed a fourth one for my pie here, and that is just to understand this truly is an emergency. The HELP syndrome is oftentimes preempted by preeclampsia and eclampsia. Preeclampsia is a condition that includes hypertension, kidney failure, liver function issues, and edema in patients. Perhaps you guys have heard preeclampsia versus eclampsia. Really, the only difference in the two is a seizure. If this goes untreated, and now your mom is in seizure, and so the advancing of eclampsia and preeclampsia is really when we get into the HELP syndrome. Let's talk about hemolysis. So the definition of hemolysis is basically just simply destruction of red blood cells. The problem being, you all might remember that red blood cells, one of the biggest things they do is they contain hemoglobin. What hemoglobin does is it carries oxygen. That is in your blood where the oxygen is actually carried, is in the hemoglobin. And so without that oxygen going to the mom's organs, you can start running into, again, multi-organ failure and permanent damage. The EL, as mentioned, stands for elevated liver enzymes. This is due to damage to the cells due to that lack of oxygen. And it can actually cause severe damage, and it can unfortunately cause some permanent damage to the liver. The third piece of this nightmare, this circle of death, is a low platelet count. Now, you guys may remember, maybe not, your platelets are what help you clot. And so if those aren't in place, you can have some internal hemorrhaging that has nothing to do with trauma. I mean, just spontaneous hemorrhage. That could be in the brain. It could be in one of the organs of the mom. It could be, any of those. And this is where we really are starting to get down in the weeds and really concerned about both maternal death as well as fetal demise. As mentioned, this one, true emergency. Your mom has hypertension. She can't clot. She can't carry oxygen around to her organs, and this oftentimes, as mentioned, leads to organ failure. The hypertension making it even worse because now the blood is shooting out of those vessels, secondary to the hypertension. Some of the facts around HELLP syndrome, luckily it is relatively rare. Um, we saw it a lot at Flight for Life, only because those kind of hospitals out there want to get them out of their hospitals into Denver. So you would typically see it more often if you were part of a crit care or a flight crew. Mortality rate, I guess I didn't get it in here in my presentation, but it's somewhere around 3 to 5%. Now, interestingly, they being the researchers, um, they really have no idea what causes this, and that sort of makes it even scarier. They have talked about, perhaps it having a genetic um, relationship, or perhaps just crazy hormones that cause this triad, but they honestly don't really actually know. Oftentimes, you're going to see this in the third trimester, but interestingly enough, understand that this can happen postpartum. This can happen up to a week or 2 weeks later, as those hormones are kind of still raging, and and you see you can have those symptoms after the baby is born. Risk factors are somewhat the same as our previous previous complications. Preeclampsia, which is that elevated blood pressure. Um, if the patient has a history of previa or abruption, that might put them at a higher risk of falling into the HELLP syndrome category. Interestingly enough, patients less than 25 years of age and Caucasian are most affected. And then, as mentioned, hypertension and genetics. So this is how you will oftentimes see your patient present that's in HELLP syndrome. They're going to have a headache, perhaps a nosebleed and blurred vision. That oftentimes is things that we see in patients with hypertension. So these are probably your first clues of a patient that might be in a hypertensive crisis or be in the HELLP syndrome. This one, interestingly, is going to have upper quadrant pain, and that is actually secondary to the liver and the decreased liver function. You might note some edema, also relative to the hypertension. There may be some dizziness. And then in the worst cases, you're going to have preterm labor, which actually goes along with HELLP syndrome quite often. And also, worst case scenario, you're going to have a pregnant patient in full seizure. So that's it for the HELLP syndrome. Once again, any questions, please feel free to email me, and I'll be happy to answer them. And so now we are on to my nightmare call in Gilpin County. This is only, I think I was only up there about 2 months, 2 or 3 months when this all went down. So here's the 911 call. I love when she asks, "Where is your emergency?" and his answer is, "At the house." That always gives me a chuckle. So this is the page going out. This is what we wake up to, as well as all the lights in the building, the station coming up. Sorry, my recordings aren't the greatest here. All right. And again, I apologize for that audio, but I am woken up at 2 o'clock in the morning to a call for a 34-year-old female patient, 30 weeks gestation, and unfortunately, her water is broke. Indeed, can we get Flight for Life on standby, please? Or medevac or whoever is the closest helicopter. Because unfortunately, I know exactly what this complication is that she's talking about that has a potential for uterine rupture. But I would suggest that the reason I know what this is my history with crit care. I don't think this is something that's really very well taught in paramedic school and certainly not in EMT classes. Um, but as mentioned, I know exactly what this complication is. And in my mind, I'm thinking it is the dreaded cerclage. So the cervix in this diagram is going to be the lower part right in here. So this is the uterus, obviously, and this is basically the floor, if you will, of the uterus. Um, Typically speaking, in normal ops, it's actually open or allowed to open to allow for menstrual material to be extracted, as well as to allow those little swimmers to get up in there and get attached to an egg. Um, what it's supposed to do in pregnancy is firm up and basically close while that baby's up in there cooking. But in a incompetent cervix, which we'll see here in a minute, unfortunately, that doesn't happen. Now, I've always thought, and every time I've seen one of these diagrams, that the female body part diagrams always seem to look like a gazelle. So if you ever need to picture the female anatomy, just think of a gazelle. So as noted, in the instance of the incompetent cervix, it just does not close up or firm up. So you can see here, the cervix is closed and you've got a nice stable mucus plug in place. Unfortunately, in the incompetent cervix, the mucus plug does not form and these two walls do not come together. And so what happens is the mom and dad need to make a decision. This is typically always found in the first trimester, very early in the pregnancy. And so mom and dad need to make a decision. Are they going to not carry the pregnancy, or are they going to have a procedure done that is called a cerclage? And so what a cerclage does is it actually surgically sews the cervix closed. And it's actually anchored to the uterine wall. And so there's good things and bad things about that. The benefit being we're saving our baby, but the downfall is the only way in which to deliver this baby now is by C-section. Vaginal delivery is not an option anymore. Reason being, as that baby is trying to bust through the cervix, it's actually pulling on the walls and pulling on those stitches which are attached to the uterus. So the considerations being heavy bleeding, much more than a previa or a abruption, as well as the baby just being stuck there. So this is a scary call. You're now kind of fighting for both the mom as well as the baby. So understand that this patient, if you hear the word cerclage, just start thinking transport to the appropriate facility. Clinical presentation here really is just going to be the patient is in preterm labor and there's some bleeding involved. This also goes back to getting a good history and really understanding any complications that the patient is having with this pregnancy. So I was preaching a history before, so I'll tell you what this patient was. So she was gravida 0. Oh, I mixed those up. She is gravida 2, para 0. I apologize, I mixed those up, which leads me to believe that she has had a complication with a previous surgery because she's had 2 pregnancies and 1 delivery. She is 33 weeks. Her membrane was not intact. Initially, when we got there, she was having contractions every 3 to 4, but just to make things even more scary, as the call went on, she actually got down to contractions every 1 to 2 minutes. She was current with her prenatal care, as well as compliance with that prenatal care. She did her doctoring with the OB/GYN group out of university, which I'm sure you know, many complicated OB patients go there. And again, to add to the fun, this baby was breech and again, preterm. Mother was healthy and no reported drugs or alcohol. On my assessment, ABCs were self-maintained. She was very, very anxious. You know, sometimes when you see on TV that very dramatic, please don't let me die, please don't let me die, that actually was her. She had been educated about her cerclage by her physician, and she knew what kind of danger she was in. She literally kept yelling, "Don't let my uterus come out." I know that sounds silly, but she is yelling this at us pretty much the whole time. Vitals are within normal limits, no blood pressure issues. Nothing really to talk about in the secondary exam other than I did note that the baby was low in the belly, which again is not a good sign. And of course, her membrane was again not intact. So our treatment plan for this patient, ABCs of course, we're really going to keep an eye on those vitals. O2 because again, why not? Let's unless she's 99%, I just feel like these patients need O2. Now, unfortunately, she was on the second floor of a house which was under construction at the time, which meant there weren't even any handrails on the stair steps. And so, thank goodness for Timberline Fire, who is our partner up there. They showed up in full force and were able to get her down to the ambulance via stair chair. Once in the ambulance, the plan was to, get an IV going and consider an IV bolus. And absolutely, this is a chopper go. But unfortunately, no chopper for me. So as they're getting her down the steps on the stair chair, I run out to the ambulance and oh shush. I run out to the ambulance and I'm going to start getting the IV set up and get the ambulance ready. And just after hearing that I don't have a chopper, I walk outside to this. So the fire department being very helpful. They're a bunch of just absolutely great guys and gals, and they've helped me out of jams a ton of times. But they had made the decision to turn the ambulance around in the driveway so that we had a clear shot out once we came out with this patient. Unfortunately, this being a snowstorm, the ambulance became high centered between a retaining wall and a rock, which was, by that I mean boulder, which was covered by snow. Now I'm getting a little concerned. Okay, you guys get the point. Uh, you can perhaps note in my voice that I'm starting to get a little concerned about this whole operation. And so just after walking out to these firefighters trying to push the ambulance out, the front wheel, front driver's side wheel of the ambulance not touching the ground at all, I get another message from dispatch. So as you can tell, in addition to all of this, radio ops were not necessarily optimal that night. So what the docs at university were wanting me to do is to administer tocolytics. And so my question for you all, do you know what tocolytics are? The paramedic group here, and do you carry tocolytics in your ambulance? Let's talk about tocolytics a little bit. So again, this is a medication that I was familiar with and comfortable with only because I'd worked for a crit care system. This is not something that your typical paramedic or EMT is ever taught about. So tocolytics are not necessarily a class of medication, rather they're kind of a group of medications. Obviously, their job is to stop contractions. That's what the term tocolytics means, is to stop contractions. The different medications that are used for this actually have different actions. The one we most often gave at Flight for Life is either going to be an IM injection of a medication called terbutaline or an IV drip of mag sulfate, which of course we all carry in our ALS ambulances. So to the paramedics who are watching this right now, I ask you again, what would you do? It is not in our Denver Metro protocol to, and I'm not familiar with your guys' protocol, but it is not in our scope of practice relative to the Denver Metro protocols to use mag sulfate as a tocolytic. We carry it and we use it for a whole bunch of other things, but we don't use it as a tocolytic. So something to consider. What exactly would you do? I did run into Pete Bellman just about 2 weeks after this call, and I sort of explained the call to him, and his eyes just sort of started getting bigger and bigger. And uh, I asked him if I would have got in trouble if I would have, taken the order from the docs at university and actually administered the mag sulfate. And, Pete's a good guy, and he just kind of looked at me and said, well, sometimes you got to do what you got to do. And if you could make a good case for it, then yeah, he would be, probably would have been okay with that. Now, luckily, I wasn't able to get a hold of the docs at university, and so I never did actually receive the order. So let's recap back at this circus. I have a pregnant patient, which I'm already not happy about, who has a cerclage in place and is contracting in a snowstorm, can't get a helicopter. I have a doc who wants me to give a drug that might get me in trouble, and my ambulance is stuck in the snow. So again, back to Dr. Velman and Scott Phillips and Tom Canlin, the three of them always had such a good way of trying to get people to just stop take a breath, um, and, uh, and just try to recap. But I will tell you that much like this little guy right down here, I felt like a monkey juggling a football. Now, for those of you who really know what that saying actually says, that is truly how I felt. But for the family, atmosphere here, I'm going to say I felt like a monkey juggling a football. So I did. I stopped, took myself a big, deep breath, kind of looked up at the sky. I'm like, I can't really believe all this is happening. And also, I was perhaps looking for cameras to see if I was being punked. But at that moment, finally, things are starting to look up. Things are starting to go our way. And what I meant by I could use your hands for a couple seconds is get in here and help me. I need an IV, I need oxygen, and a female would be fantastic. Again, I apologize for the audio there, but what I was asking for is to see if flights would go up to Floyd Hill. Floyd Hill is an area on I-70, and perhaps some of you are familiar with it. It's right before the huge hill that kind of drops down into Idaho Springs. Floyd Hill is a historic rendezvous site for Flight for Life and ambulances that are kind of screaming out of the mountains with sick patients, and so I knew that even though they couldn't make it to Gilpin County, I knew that they'd be able to, if they flew low, they could basically follow the interstate up and meet us there. So I thought I'd give it one last attempt at getting a helicopter. And after a few moments of wondering, finally we got this. Okay, finally, things are going our way. So I gave flights a call. I talked to the pilot real quick, and we got moving. And again, that last one was we're going to be emergent to Floyd Hill. So thank goodness we are headed in the right direction. Now, EMS pilots, they can be a bunch of funny guys. So I had flown with this pilot for a long time, and we had a good relationship and a lot of banter back and forth. But he lands and he gets out and walks up to me and he's like, "Hey, Ed, why don't you just drive this patient down to the U?" So after holding myself back from stabbing him in the neck with a pen, I explained to him what the situation was. And again, going back to what I made mention of earlier when talking about air medical, it's those two reasons that you should call air medical. One being the medications that they can provide, and two being the speed. So what we needed here is that tocolytic, which I knew Flight for Life carries, and to get that on board as absolutely soon as possible, because now is when the patient was contracting every 1 to 2 minutes. So finally, we got to the helicopter. We administered Turbulene. Very luckily, her contractions ceased. They had a very quick 6-minute flight down to University from Floyd Hill, and she immediately had a emergency C-section. and it was a girl. Now, this is not the patient or the baby. I just thought it'd be nice to throw this in at the end of the talk here. So to summarize, the things to take into consideration are bleeding, amount of bleeding, blood pressure, mentation, pain, no pain. And again, always remember that your transport decision is tremendously important in these OB patients. So I hope that sitting through this at least makes you guys at least a little bit more comfortable with these patients. Again, I know I'm not. You know, maybe Billy is. She's a nurse, so nurses are much more well versed in these baby type things. But being a male and being a paramedic, this is not, and for other reasons, this is not natural to me. So hopefully we have made you a little bit more comfortable in recognizing these different complications and how to treat them. As mentioned, if you have any questions at all, you may feel free to email me at the email listed there. And other than that, thank you all for your attention. I appreciate what all of you guys do. And that's it.